Thank you very much. So I'm very happy to be here. I wish I could be with you for this meeting, but I couldn't make it this time. Next time, inshallah, I will be there. So I will talk about PCB or DES in current management of coronary artery disease. I know that the Shirket's topics similar to my topic. I hope we don't have that much overlap in this talk. Apologize, Shirket, for that if we have any overlap. So I think we have to know that there is a non-plateauing 2 to 3% annual event rate after DSPCI. We have every year 2 to 3% event if we plant a stent in any coronaries, and also syntax studies tell us if we have longer stent and much more stent in a patients, and also if we have a smaller diameter, we have more mortality rate, right? So if we have less extensive stenting, our result will be comparable with a CABG operation. So it's important to use less stent in our routine practice according to syntax study. So why does the KISSA fail? So I think there's some mechanical issues, and also diabetes is also very important. If we have a multiple disease or chronic catholic lesions, LAD lesions, small vessels, we have more restenosis rate after DES. And also, if we have a diabetes, again, CTO, instant restenosis, long lesions, and small diameter, we have worse outcome after DES. So if we compare DS and DCB, we can talk about advantages. Like, if we treat this stenosis with DS, there will be no vessel enlargement, but also we could have some neointimal proliferation after DS implantation. So because this cage, there will be no anymore vessel enlargement. But if we do DCB, so we have a chance to have vessel enlargement plus plaque regression, or we could have only vessel enlargement, or we can have only plaque regression. So in three-way, we could have a better advantage over DS. So look, other advantages of the DCB over DS. First of all, we have a low risk of acute vessel occlusion. There is no stent thrombosis because it's a never-ending story. There is no start caging, so the origin of the lateral branches will be free. Also, DCB allows maintenance of post-PCI vasomotor function and allows the normal function of the endothelium to recover. And also, there is late lumen enlargement. This is very important. After paclitaxel, 70% of the patient has late lumen enlargement. Remember that we have late lumen. We talk about the late lumen loss after stent, but in DCB we can talk about late lumen gain, late lumen enlargement. This is also advantage. Of course, it's easy of continued treatment. We could do repeated DCB, or we could do stents, or we could send our patient surgery after DCB because there will be no metal. Also, of course, we can possibly shorten the duration of that, and we could do CCT analysis after DCB. And of course, it's more preferable in young diabetic and dialysis patient. So it's also simplify the complex procedure. Then we don't have that much landing zone issues, right? Because there will be no stent, there will be landing zone issues. This is very important, actually, to reduce edge restenosis. And in patients with CTO or diffuse disease, we could avoid to have long stents, and there will be no malapposition issues or under expansion, especially in calcification or geographic mission issues. In bifurcation lesions, also we could have reduced procedural steps. Imagine that if we could do VK crush, we have to go all these steps by one by. In provisional, we have, of course, less steps, but with DCB, we don't have any steps actually. We just do DCB and go away. So it started with the instant restenosis and small vessel disease, and but now today, why don't we use these DCB all coronaries? I think we could use also small vessel disease and, of course, stenosis and small vessel disease, manual indication, but we could use them in CTO, acute coronary syndrome, bifurcation or trifurcation, long lesions or discrete lesions, left main even, osteal lesions or graft disease. But of course, we have some limitations, such as we could have recoil, acute recoil or dissection, or we could have late recoil or neointima proliferation. So, interestingly, regarding dissection, we have a very old paper. It's a 40 years old paper. That paper, they evaluated 1,000 patients, almost 1,000 patients, and 25% of them has angiographic evidence of intimal dissection, and they did angio follow-up, all of them. What they see it, if you have dissection, you have reduced restenosis rate. This is very interesting, but it may help to heal the vessel, and it may help to have large lumen after dissection. How about the DCB era? How about the effect of DCB in native coronary artery disease left with dissection? We have a very nice paper. They studied 156 patients and they followed the DCB dissection, and 48 patients has dissection after DCB. Out of 48 patients, 45 of them healed nicely. There is no dissection in follow-up. Only 3 of them remain. Even they have 5 type C dissection, and 3 of them also healed, and there is no dissection. Two of them stay as type type A dissection. Another advantage, as I mentioned to you, we could have a large, we could have late lumen enlargement. It could shown in this study in 58 lesions in 56 consecutive patients. So they did DCB and they did also QCA measurement after 46 months, and they found that there is a late lumen enlargement in this series. And late lumen increase of the tagged lesion within the observation period was 0.60 millimeter. So let's talk about briefly lesion preparation. We could, of course, we could shoot optimal lesion preparation. We can do preparation with standard semi-compliant balloon. If the vessel is not fibrotic or calcified, or we could use a scoring balloon, cutting balloon, non-compliant balloon, or a shockwave balloon even. But the balloon to vessel size has to be one to one, according to angiogram, not according to IOS, according to angiogram. So also, of course, we could use rotablation or FFR if we need it, or IOS if we need it. So if we have acceptable angiographic result, which means that there is no flow limiting dissection, residual stenosis is less than 30%, or if FFR is higher than 0.80, then we could do DCB right away. If we have suboptimal angiographic results, then we had better do DES. So after pre-dilatation, we could have very nice result with large residual angiographic lumen with minimal or no dissection. We call it stamp-like, result. In that case, I think no doubt we can do DCB. If we have a very poor result with recoil or large dissection, we have better stent. But if we have intermediate result, then we can do QFR or PD or PA measure, and we can re-evaluate. Or what I do, if I have type C dissection, I do with non-compliant balloon, I do 4 or 5 minutes long balloon dilatation, and if I see that the dissection will be sealed, then I do DCB in this intermediate result. If I still, after 4 or 5 minutes balloon dilatation, if I see still dissection, then I implant this stent. So let's see some studies. For example, this study is evaluated DCB in multivessel disease, and in study, this is a quite new study published like 3 years ago, and the number is quite good. They had 500 patients. They compare DCB versus stent, and according to their result, DCB has less major cardiac events and less major bleeding, and also less cardiac death. If you see here, especially they, they compare DCB base group and DCDS only group, and 64 patients of them DCB only, but 35 DCB plus stand. And here you see that we have a base advantage and target vessel revascularization advantage as well. How about in large vessel? We have a randomized trials. In here you see 7 randomized trials, and we have a meta-analysis of those 7 uh, trials. And in here again, numbers is quite comparable. DCB in 384, stand is 386 patients. And as you see here, we have a less MACE and less TLR in DCB arm than stand arm in this meta-analysis. This shows us the DCB for de novo lesions of the LAD lesions. I think LAD lesions is also important because LAD has more restenosis rate in after stent than other vessel sizes. It's important to see them, and they show back in 2 years follow-up. There is in terms of target lesion failure, target lesion revascularization, and target vessel failure, balloons, DCBs are better than DS. Another all-comer studies, it's a large number registry, 2,440 patients. 1-year outcome shows us MACE is 10%, TLR is 6% in the studies. But this is all-comer. If you separate instant restenosis, which the result is worse, versus de novo lesions, in de novo lesions, even results are much better. MACE is 5%, TLR is 2% in the study. I think quite impressive results. How about acute coronary syndrome? Yes, we can use DCB in acute coronary syndrome. We have some data about it. This is published in JACC 2023. They treat more than 1,000 patients, and 452 the DCB, 687 DS, and according to the study, after 3-year follow-up, and propensity matching, no difference in all-cause mortality or net advanced cardiac event. There is no difference in acute coronary stroke, major bleeding, or unplanned target lesion revascularization in the study. Another DCB in acute MI meta-analysis. They studied again more than 2,000 patients, 2,644 patients in 13 studies. They also shows us DS and DCB are similar results. So I think we can use DCB intervention wasn't inferior to DS, and we can use DCB in acute coronary syndrome. In large vessel also, we have some data regarding large vessel. Again, we have 30 days and 12 months result in a DCB versus DS group, and that the numbers are that much, not that much, but we have comparable results again. How about barification? I think barification is quite interesting topic to us because it's very complex, and the operation is acute operation is more, restenosis is more. We have again a meta-analysis, 11 studies, 2 of them are CT, 9 of them observational. They studied 2,300 patients, and they found that there is comparable efficacy in MACE and TLR, but DCB is very superior in reducing late lumen loss. So we have late lumen gain if we do DCB. And de novo lesions were the drivers of the benefit. Similar results in stent restenosis. How about CTO? Yes, we have, I think, with the advantage of CTO to use DCB in CTO. Why is that? Because we have high rate stent failure in CTOs, and we have been to the extensive stent implantation. And also, as you know, that if we do CTO PCI stent implantation, we could have underexpansion or malapposition, because we know that by time vessels normally prone to become larger and larger after CTO PCI. So DCB if it is possible. We have studies. This is a long-term result. number is for not big, 154. They follow up for 470 days, and they published that the DCB is feasible in the security side. So now uh, these are like everything is involved. And an ultra study, this is uh, a bigger number. They studied 643 patients, DCB group versus DS group, and they have angiogram follow up at 1 year in some patients, and they have clinical follow up at 3 years as primary endpoint, and they show that there is no significant in two groups between MACE, TLR, TBR, and DER. So in the study, they show that DCB is not inferior to uh, uh, DS. So even there are some studies now studying that left main. This is a small group, but it's I think important to mention it. They did DCB in left main lesions in 30 39 patients, left main patients, and they found that there's in compared with the 39 proponents matched patients who were treated with second generation DS from COBIS uh, 3 trial, they see that there is a MACE, there is no difference in MACE between stand group and DS group, stand group and the DC group. I think this is also a new era for us to treat some the net main lesions, especially if we have a stamp like result after predilatation in left main. I think we could try. I mean, or at least we could think to use DCB. So, what we need to know, we need to know some. I think some we need to discuss some regarding how long we should use adapt. We don't know yet, and we should have maybe more clear algorithm because some operators use routinely cutting balloon or scoring balloon. Some of them use NC balloon or even sim compliant balloon. How about DCB in elderly patients calcified lesions or atherectomy or after LV? Usually, I think we need to see some more data about it. But I like to use DCB in calcified lesions because in calcified lesions, I think the result is worse in DS. And also, importance of IVUS or physiology, we should think about it. Normally, so far, we do our DCB practice mostly without using IVUS. Not the, we use IVUS, but not the size the DCB diameter because we use angiogram mainly to choose our predilatation balloon or DCB balloon. And we don't know yet is there any difference between paclitaxel and sirolimus. We have some data, but it's not, I think, not finalized yet. And of course, we need more data on large vessel SD elevation environment CTO. So I'd like to thank you very much for your attendance and your patience.